Good evening to everybody. You are a huge number of visitors, so I would like to, if you don't mind, we will wait for 5 minutes more. Yes, we are huge numbers. A lot of doctors are coming. Thank you so much to be here this evening. Okay, so many people are joining us. So if you don't mind, we will start about 5 p.m. Five minutes more.
Yes, I think Josefina want to ask something, and also Sandro Viglino.
Let's check.
Oh.
Audio.
No. No, it's okay. It is.
Probably they have problem with the audio.
No, it's okay. It's.
I can hear somebody.
No, it's
so
okay.
I would like just to ask you to respect. Okay, if you can mute the microphone, please, so everybody can hear the webinar this evening. So there's so many people still coming. So probably let's wait for 2 minutes more. Cagnacci has a lot of fun because we have huge numbers this evening.
Hola a todos.
Hello, everybody.
Hi, bienvenidos y bienvenidas.
Ciao, Silvia.
Ciao. Hi, Nives.
Professor Cagnacci, buonasera.
Hola.
Buonasera a tutti.
Okay, if you agree, still waiting for some more doctors join us.
Bueno.
If you don't mind to mute your microphone, so when we start the webinar, we can hear better. Because I hear like a sound. Okay. Okay, now it's 5 p.m. So we can start our webinar. You probably know that we will record the webinar. Thank you so much to be here this evening. We have a huge number of doctors. Merci beaucoup pour les Français aussi. C'est dommage, le webinaire sera en anglais, mais vous pourrez faire des questions et on va traduire. Grazie professor Cagnacci per essere qui questa sera. I would like just to introduce Professor Cagnacci. Most of you, if you follow us, you know Professor Cagnacci, Chief of the Obstetrical and Gynecology Clinic San Martino University Hospital in Genova, in Italy. He published a lot in Climateric reviews. It's probably I would like also to suggest you to read the publication. I would like to thank you because Professor Cagnacci is always very, very busy. So we are very glad this evening to have him to speak about the oxygen and hyaluronic system on breast cancer patients. Thank you so much. And please, I remind you that we will let space at the end of the webinar for the questions. Thank you so much. Grazie, Professor Cagnacci, per questa sera. Forse non la sentiamo.
Grazie. Do you want me to start or yeah? Can I start?
Direi che possiamo iniziare. Grazie mille.
Okay. I'm going to share my Tell me if you see the monitor.
Yes, we see this. Yeah.
Okay. Thank you very much. I'm going to talk a little bit about this new treatment, rather new treatment for vaginal atrophy or genital urinary syndrome. That is the combination of hyaluronic acid and oxygen. As you know, I will make a brief introduction on the genital urinary syndrome because we are going to evaluate the effect of this treatment on all these three aspects of genital urinary syndrome. The genital urinary syndrome was defined in 2013 by a group of experts of the North American Menopausal Society and the International Menopausal Society. It was a combination, was defined as a combination of genital symptoms like dryness, burning, irritation, of sexual symptoms like lack of lubrication, discomfort or pain, impaired sexual function, and urinary symptoms, urgency, mainly urgency, dysuria, and recurrent urinary tract infection. Now, the main symptoms of the genital urinary syndrome is by far the vaginal dryness. Vaginal dryness is the most frequent symptoms, and the one that you see defined among the vaginal. There are some microphones that should be mute. And is defined vaginal dryness as one of the most bothersome symptoms of women in menopause. This is a survey performed in Italy on 1,000 people or women that define vaginal dryness along with the urinary disturbance among the most bothersome symptoms of the post-menopause, along with you see hot flashes and sleep disturbance. So it is very important to treat this type of disturbance. And indeed, vaginal dryness is the main symptoms of vaginal atrophy that define vaginal atrophy. There are other symptoms of vaginal atrophy like dyspareunia, burning, itching, dysuria, and the objective sign of vaginal atrophy, along which the pH, modification of pH, and of the maturation index. Now, when we combine the vaginal dryness with an increased pH above 5, and there is the presence of objective symptoms evaluated by the physician, like vaginodiasis, mucosa pallor, ruga thinning, fragility, petechia, well, we may define, or at least this was used to define atrophy, vaginal atrophy, in two epidemiological studies performed in Italy: the Angel study that investigated the prevalence of vaginal atrophy in the menopausal transition, and the Agatha study that evaluated the prevalence of atrophy, vaginal atrophy in postmenopause. I will show you, and we defined that in those studies, we defined that when a woman suffers from vaginal atrophy, report to the physician, I suffer from vaginal atrophy, in 97% of the cases, she has vaginal atrophy. So the symptoms of vaginal, this is true for postmenopausal women, the symptoms of vaginal dryness is almost identified in almost 100% the presence of vaginal atrophy. And here you see the epidemiological evidence that we had in our two epidemiological studies in the transition, the menopausal transition from 40 to 55 years of age, and then in the postmenopausal 1, 2, 3, up to 20 years after the menopause. You may see that these symptoms are common, are rather frequent also at a young age, like women between 40 and 45. 12%, 18% of these women suffer from vaginal dryness and vaginal atrophies in this at this age, and the figures arrive to 50% in the period between 52 and 55. And also in the postmenopause, we are used to think that vaginal atrophy is a late manifestation of the menopause. Instead, you may say that about 65% of women already have a diagnosis of vaginal atrophy 1 year after the menopause, to increase then to 80-85%. Now, among the genitourinary syndrome, among the symptoms of the genitourinary syndrome, vaginal dryness is by far the most bothersome symptoms, more than dysporenia, more than itching, more than burning, more than dysuria. So the treatment of vaginal dryness is most important. It is very important to have a satisfactory response for the woman. Now, there are other methods to define vaginal atrophy, and one of these, the most common, popular way is the use of the vaginal health index. You see, the vaginal health index is a combination of the evaluation of different aspects of the vaginal mucosa, like the elasticity, the secretion, the type of secretion over the mucosa, the pH, the characteristic of the epithelial mucosa, if it shows petechia, if it bleeds, is friable, and if there is moisture above the vaginal mucosa, like none or moderate or minimal. There is a score for each of these different aspects, and when the score is below 15, you may make the diagnosis of vaginal atrophy, along with the symptoms that in general is vaginal dryness. So we used, I explained this to you because in the following in the studies that I'm going to present, we used this scale just because it is more reliable, just more detailed, and is more used in the clinical studies to evaluate vaginal atrophy and its modification during treatment. When you have vaginal atrophy and vaginal dryness, you may use lubricants to favor intercourse or moisturizing agent to treat vaginal dryness. But these require frequent administration of the agents, and that these are always are often discontinued because it is bothersome to use this treatment continuously. Then you may use hormones that can stimulate hormone receptor in the mucosa, like estrogen, Depo, and progesterone, basically, or phytoestrogen, that stimulate the estrogen receptor and favor the trophism of the mucosa. We may also have general treatment, systemic treatment like ospemifene that every one of us knows, that goes to stimulate the estrogen receptor, but is given by mouth orally, and it selectively stimulates the vaginal mucosa with no systemic side effect. And finally, we have physical method like laser, radiofrequency, electrophoresis, and vaginal oxygen plus hyaluronic acid. And I'm going to show you the data on this treatment that we used in women in breast cancer survival. Why vaginal oxygen and hyaluronic acid can be effective? Well, because we know from the literature and basically from the surgical literature that increasing the content of the tension of oxygen within a tissue stimulates collagen formation from fibroblast. You see here on the left that if we increase the PO2 within the tissue, collagen, the formation of collagen progressively increases. And this favor wound healing in surgery, wound healing, and stimulate revascularization. Revascularization, so because the oxygen stimulates the production of VEGF, vascular endothelial growth factors, that increases the number of vessels, increases circulation of the tissue and make the tissue more trophic, stimulating both the vascularization and the collagen formation. Along with oxygen, hyaluronic acid, if is in low molecular weight, like 2090 kilodalton, when it is a big molecule, it remains on the surface of the mucosa. But when it's given in a low molecular weight, it can enter the mucosa, and entering the mucosa, it can go to the fibroblast and stimulate also the formation of collagen. So the two components, the oxygen and the hyaluronic acid, synergize to increase the collagen formation and the vascularization of the mucosa. This type of treatment, you saw this type of treatment already in the video, and basically is made by a machine. Oxygen is made by a machinery that from air, concentrate oxygen to 95%, pure oxygen to 95%, and then this oxygen is delivered through a cannula inside the vagina. And this delivery lasts for 10 minutes. Generally it is used for 10 minutes. It is given only oxygen, and the last 5 minutes, this is mixed with a solution of hyaluronic acid. The solution of hyaluronic acid is inserted into the cannula, and then for the next 5 minutes, hyaluronic acid is delivered inside the vagina by the flow of oxygen that also enter into the vagina. So the entire treatment is 15 minutes, and is given for treatment is scheduled every 15 days for 5 times. So the entire treatment lasts 2 months and a half, in which every 15 days we perform this 15 minutes treatment. The schedule at the time for the 15 minutes treatment and the schedule performed every 15 days for 5 times was proposed by these authors, Dr. Condemi and Professor Ciavattini, that treated natural menopausal women and showed an effective response in the vagina in the treatment of vaginal atrophy. So on this basis, we applied the same treatment with the same time schedule, with the same period of treatment of 15 minutes to women that were breast cancer survivors. And we published the results in 2023 in Climateric, so in a very prestigious journal. Here, why we choose breast cancer survivor? Because these women are all often on hormonal therapy, basically on tamoxifen or aromatase inhibitors that deprive the vagina markedly deprive the vagina of the estrogen stimulus. And these women, more the other they suffer from, that survive from cancer, like hematological cancer or other types of cancer. These women are those that suffer particularly of gynecological side effects, and in particular vaginal side effects, genitourinary symptoms. These are the main symptoms of these women. So we think that this group of women was particularly to treat the group of women was particularly important to improve their quality of life. We selected 40 women that we recruited with 40 women that surviving from breast cancer. The mean age was 46, you see. They were rather teen, mean BMI of 18. Almost all were in a stable relationship, and they had performed chemotherapy in previous chemotherapy in 90% of cases. These women were either on aromatase inhibitors as adjuvant hormonal therapy or on tamoxifen, with or without a GnRH analog. That was dependent on whether they were in postmenopause or whether they were in premenopause. If they were in premenopause, the GnRH analog was used to stop the production of hormones by the ovary, and then aromatase inhibitors or tamoxifen were added to the therapy, to this to the picture to further reduce the estrogen stimulus. And I want to we go directly to the result. Here you see the modification of the vaginal health index score. You see the red line, as I told you before, is the cutoff to define vaginal atrophy. A cutoff, it is a value of 15 when you have a vaginal index of above 15, you don't have vaginal atrophy. When you are below 15, you have vaginal atrophy. So you see that at the time 0, when we started the first treatment and we performed the first evaluation, you see that this vaginal health index was very low, was 9.5, so much lower than the cutoff defined used to define vaginal atrophy. Then, however, after the first treatment, you see that the vaginal health index increased immediately to 11.8, and after the second treatment, it went to 13.5, and after the third treatment, it went to 40, arrived close to the cutoff, and after that, it went above the cutoff. So we reduced. Basically, most of the women were not more suffering from vaginal atrophy. And 15 days after the last application at V5, you see that the value were well above the cutoff defined for vaginal atrophy. If we express this data in percentage of women with vaginal atrophy, you see that at the beginning, basically the women that were the percentage of women below the cutoff of 15 was 100%. All women had vaginal atrophy. Then, after one application, only 85% still had vaginal atrophy. After two applications, 50%, just to arrive to the last evaluation at V5, where we found that only 18% of women still had vaginal atrophy. And so a reduction basically of 82%. A reduction of 80% of vaginal atrophy. The last column is the follow-up. The follow-up was performed 30 days after the last visit, after V5. So 45 days after the last application of oxygen hyaluronic acid. And you can see that the percentage of women without vaginal atrophy remain basically unchanged. Here you see the same data. On the top, you see the improvement of the vaginal health index that went above the 15 value, or the cutoff of 15 value. And below, you see other two symptoms that we checked. There was the visual analog score for pain at intercourse, and the visual analog scale score for burning. And you see how this value, in conjunction with the improvement of the vaginal health index, as these values basically both decline significantly and remained reduced also in the follow-up that was performed basically 45 days after the last application. What is more interesting and dramatic is the increase that we observed, the rapid increase that we observed in the lubrication, in the item of lubrication, the item of the vaginal health index score that identify lubrication. You see how after the first application we have a rapid increase in lubrication that further increase after the fourth application we reached at V4 the maximal value of lubrication. This is important because it gives us a clue on the second aspect of the genital urinary syndrome, that is sexuality. We improved here the first item, vaginal atrophy and vaginal dryness, basically, but we had to improve also the other items of the genital urinary syndrome, sexuality and urinary disturbances. And indeed, we know that vaginal dryness, the improvement of vaginal dryness may have a clear impact on sexuality. Here in this epidemiological study, we showed that vaginal dryness reduces all the items of sexuality, like reduces desire, reduces arousal, reduces lubrication, reduces the quality of the orgasm, reduces satisfaction of the intercourse, of the sexual activity, and reduces dyspareunia, increases dyspareunia. So dryness, as you see, enters in all the aspects of sexuality. Entering in all the aspects of sexuality, and improving dryness may lead to improving sexuality. Indeed, when we look at the data on sexuality of these women, you see here are not reported all the evaluation, but is reported the pre-treatment value, the value at visit 3, and the value at visit 5. That was the last evaluation, 15 days after the application, and then the values at follow-up, 45 days after the last application. And you may see here that there is an increase progressive increase in all the
Professore,
items. Sì.
Mi scusi, non vediamo più la sua presentazione.
Non la vede più perché siete entrati voi.
No.
Sì.
Se può per favore ricondividere lo schermo. Grazie. No,
adesso lo vede?
Adesso vedo il suo schermo, sì. Ok, perfetto. Sì.
Se state fermi magari non riesce. Quindi you see that the increase desire, arousal, lubrication, orgasm, and satisfaction, all the items of sexuality increase with the treatment. So this is very, very important from our point of view, because this has a clear impact on the quality of life. These women, breast cancer subjects that are rather young, you see the mean age was around 45. We also evaluated the third aspect of the genitourinary syndrome, that is the urinary syndrome. And the urinary syndrome were evaluated with the urinary distress inventory. Is a scale to evaluate to quickly evaluate the urinary syndromes. These women were not really were not really symptomatic, but yes, at V0, they still had values of the score that were decreased after the treatment to V3 and V5. So we have an improvement also in this score. We further, in a subsequent analysis that was published in 2015, recently, we wanted to specifically evaluate the effect of this treatment, vaginal oxygen plus hyaluronic acid, on lower urinary tract symptoms evaluated through the urinary distress inventory. You see, we recruited 85 women. The studies was performed in 85 breast cancer survivors. Their mean age was 48. They were still thin, body mass index 22, 60% at the delivery. The number of pregnancy was around 1. Some of them suffer from urinary incontinence, 21. And then there were several aspects. For example, they had the diagnosis of breast cancer 3 years before, so they were still on treatment. They were still on treatment, on hormonal treatment. And you see type of endocrine adjuvant therapy. 15 of them for the type of hormone for the type of cancer that they had were on no therapy, 17% of them, and the other were on adjuvant therapy with either tamoxifen, 25%, or aromatase inhibitors, 74%. Plus, 75% of them were on GnRH analog because they were not in menopause. So we had to inhibit the ovaries. We had to inhibit the ovaries and then to add tamoxifen or aromatase inhibitors. I want to show you, first of all, the effect on the vaginal health index because in this case we have doubled the number of women that were published before. The original study was performed on 40 women. Now here we have 85 women, and still the data remain the same. So as to say, this comforts us because the data are real. It was not the case that it was not by chance that we had that result. So here again, we confirm that at visit 0, the vaginal index is very low, 9.7, and then at the end of the treatment, visit 5 is 16.2, and at the follow-up period, 45 days after, is still higher than the baseline and still higher than the cutoff. Then I will show you the HUDI score, the urinary distress inventory. In this case, we selected only those women that at the baseline had symptoms, at least one symptoms of urinary disturbance, either irritative, incontinence, or obstructive, and any type, but at least one symptom of urinary disturbance. So the baseline urinary distress inventory was 24, and then it declined progressively from visit 0 to visit 2 to visit at the end of treatment. At the follow-up, we had a lower score of the UD score that was significant. But you may want to know which symptoms decline more during the treatment. And the UD score, the urinary distress inventory score, can be divided. They can basically explore 3 different symptoms. Irritative symptoms, like overactive bladder, urge incontinence, stress symptoms as leakage, spontaneous or induced by stress, and obstructive symptoms as difficulty to urinate or dysuria or pain during urination. So it evaluates these different aspects of the urinary symptoms, and you may see that the best response was on irritative symptoms. We have a nice reduction from 9.2 to 6.6 to 5.5 at visit 5, and then a follow-up still remain different. I want to recall that when I defined the genitourinary syndrome, the urinary disturbances that are associated with the genitourinary syndrome are those defined as irritative disturbances, because those are the ones that are more related to estrogen deficiency. Then also we have an improvement in obstructive discomfort symptoms, mainly because of the item that of discomfort during urination for the improvement, the external improvement of the vagina and the condition of the vagina, and also a reduction of the stress symptoms. But I want you to observe the column at the left, at the right of your monitor, because you may see that in the last 3, the p-value visit 5 versus visit 0 was significant. So at the end of treatment, we have a significant reduction for irritative symptoms, for obstructive and discomfort symptoms, but not for stress symptoms. The significance was obtained at follow-up. So after 45 days from the last treatment, when we have a reduction also in stress symptoms. And this is probably because it takes more time to have an improvement in the collagen in the urethra, so it's more difficult to achieve this effect. It takes more time to have an improvement on this disturbance. From a graphical point of view, you see here the classical reduction, the beautiful reduction in the urinary distress inventory score, with the reduction from baseline to VIST-5 treatment, and at follow-up 45 days after the last administration of the last application of the treatment. And expressed in and if we express it in percentage, we divided the data that we had from the urinary distress inventory in tertile. So the women in the upper tertile were those that we defined as having severe symptoms. The women in the lower tertile were those that we defined with slight or none symptoms. And you see here that women, they were at baseline, almost 14% of women were suffering from severe irritative symptoms. So very bothersome, but when during treatment, the percentage of women was reduced to only 4%. So we have a big improvement in these irritative symptoms. And then also we have an improvement, but less pronounced because the baseline data were less present, less frequent in stress and obstructive discomfort disturbances. And here instead you see that the women that had the none or mild irritative symptoms increased from 50% to 85%. So basically we had a reduction, a complete reduction of a strong reduction of severe irritative symptoms mainly, and an increase in the percentage of women that had none or very mild symptoms. We also performed a further analysis to see if all the women responded in the same way. Basically, there were women on aromatase inhibitors, there were women in premenopause with the urinary analogs, there were women on tamoxifen. Did they respond similarly to this treatment? What we observed in the UD total score is, and in all the subscale, that the response was related to the baseline values. Higher were the symptoms at baseline, more was the response. Higher was the response to the treatment. Then, among the other factors, for the total urinary distress inventory, it was important the use of aromatase inhibitors that, as you know, now are those that are more frequently used after breast cancer. And the use of aromatase inhibitors increased the response to the treatment, to the vaginal oxygen pure hyaluronic acid. So those women that were on aromatase inhibitors responded more than those women that were not on aromatase inhibitors. Irritative symptoms, we had a better response in women with the GnRH analog, so basically in women that were in the perimenopause or premenopause, whereas we have a reduced response in women on tamoxifen. Women on tamoxifen seems to suffer more than others from stress symptoms. Women in breast cancer on tamoxifen seem to suffer more than those on aromatase inhibitors, to have more symptoms of urinary incontinence. And this is confirmed also by our data, showing that the response of these women to treatment is reduced if they are on tamoxifen, whereas it's increased if they are on aromatase inhibitors. This is basically may help you in deciding. You may always try to this type of treatment, but if the woman that you have in front of you is on GnRH analog and aromatase inhibitors, clearly is likely that respond much better than another woman that is in front of you as is in tamoxifen, for example. I would like to share the last two slides are just a preliminary value, a preliminary data showing, and actually these were obtained on 20 cases, but now we have 85 cases that have terminated this follow-up. This is the first 20 cases showing the long-term effect, of the treatment. Basically, we perform a treatment that lasts 2 months and a half, and then when should we repeat the treatment? Should we repeat frequently or not? How long it lasts? Because this is a question that our patient can make. Here you see basically the vaginal health index score, but the effect is similar also for the UD score. We have an increase, an improvement until the follow-up, and then the recall 1, the recall 1 and recall 2 basically were performed 10 months and 12 months after the last treatment. So this is the long-term effect. As you can see here, the vaginal health index score remain much higher than at baseline. So the effect lasts for a long time, and maybe last for a long time. And this is also true for dyspareunia, where you see the recall 1 and recall 2 for the VAS values of dyspareunia and the VAS value for burning. And this also for the index of sexuality, the functional the sex function index. You see that all the items, desire, arousal, lubrication, organ satisfaction, and pain, remain higher than at baseline after 12 months of treatment with with vaginal oxygen plus hyaluronic acid. Maybe I am not sure if this can be applied to the physiological postmenopausal women. Maybe these women needed this treatment to regain the sexual activity, and then the sexual activity maintain the health of the vagina and the genitourinary symptoms. So we are not sure of that, but for sure we have whatever is the mechanism. Once we have performed this type of treatment, we may say that the effect, the benefit can last for a long time, on all the aspect of the genitourinary syndrome. So in conclusion, we may say that this type of treatment, pure oxygen and hyaluronic acid, is easy to use, can be used by everyone, is well tolerated. We don't enter in this discussion, but basically we had no withdrawal from the treatment. There are no side effects during the treatment, and they can treat all the different aspects of the genitourinary syndromes, the aspect of the vagina, so of vaginal atrophy with its dryness, the sexuality items, improving sexuality, and also, as we demonstrated recently, also urinary symptoms, in particular irritative symptoms like urge incontinence and overactive bladder symptoms. Thank you very much for your attention. I'm here for some response.
Thank you so much, Professor Cagnacci. So if you have any questions, you can write in the chat or can ask directly to Professor Cagnacci.
Chat. Come mai la relazione che il professor Cagnacci è lingua inglese, c'è scritto. Because there were people connected from outside. Maybe I will ask for protocol different in frequency and duration. There are differences in some type of protocols that are used, for example, for the vulva or or for the treatment of vaginal infection, but they are not really much different from this one. No, maybe in some cases they've been used intervals between one treatment and the other of 1 week. But in general, we may say that it has been a prolonged administration during the treatment. It has been prolonged for more than 15 minutes in the case of vulvar disease like lichen and things like that, where it has been used protocols in which the administration of oxygen and hyaluronic acid has been prolonged up to 20 or 30 minutes. But for vaginal atrophy, we tried to prolong the administration, to prolong the number of the administration to 7. We have the data already in the small number of subjects, and we did not obtain any advantage. So after 5 applications, we obtained a value of an improvement of the vaginal health index that not improve further if we continue the treatment with other treatment for other 2 times, for example, to have a 7 administration. When do you repeat the treatment then? We repeat the treatment when it actually we are rather scheduled. In other words, we perform this treatment for research right now. So we don't change the frequency of the time schedule of the treatment. We are now trying to repeat the treatment after 1 year to see if we may increase further the improvement that is maintained, or if we can regain in those women that the treatment didn't last so long, if we may regain the same effect after 1 year. But we don't, in this moment, we don't have a personalized response for each treatment for each woman. So my suggestion is that outside the clinical trials, you perform the treatment whenever it is necessary. So if the woman says, well, I still have vaginal dryness, or I had it recurs it recurred the vaginal dryness. So in that case, you may repeat the treatment. Non vedo altre. I don't see any other comment.
Any other question? Yes.
Is there any contraindication for the treatment? No. There is no contraindication. We are giving oxygen and hyaluronic acid. There are data that, for example, vaginal infection improves during this treatment because anaerobic bacteria are killed by the oxygen, whereas lactobacilli survive the administration of vaginal oxygen. So you may have an improvement of vaginitis, of candidosis, and of viral infection. So basically, you don't really have any contraindication. Did the patient use other adjuvant treatments during the follow-up period? We did not prescribe any adjuvant treatments during the follow-up. So we expected they didn't. They expected they didn't because they already came here without any treatment or with having had treatment they were not effective. So we did not expect we did not prescribe any treatment, but for sure maybe they regained their sexual activity, and that sexual activity probably was the positive effect that we saw in the long term. Look, have you experienced in combined treatment with estrogens in non-breast cancer patients? No, I don't have experience. I think that it may help. It may help. It may help. The two may synergize together. So there is no contraindication to perform both. Longer treatment in time, not in length. Has a detrimental effect on the vaginal mucosa? No, this is a concept that is motivated by the laser, because whenever you give the laser, you give a small lesion on the mucosa that someone says it may bring to cicatrization, to a restriction then of the mucosa. In this case, you don't induce any lesion. You only stimulate the tropism of the mucosa. So clearly, this is not a problem with this type of treatment.
So we are probably close to 9:00 p.m. So we would like to thank Professor Cagnacci. The presentation was brilliant, very clear. So thank you so much.
Thank you all.
If you have any more questions in the next days, you can write us, and we will be very glad to answer you. Thank you so much again.
Thank you to everybody
for the participation.
Thank you.
Ciao Angelo, buonanotte.
Ciao. Ciao Gabriele, ciao.
Ciao. Complimenti come sempre.
Grazie.
Sei sempre sul pezzo. A presto.
Ciao.
Ciao.